So here's all the different sites that could take place of an ectopic pregnancy. It doesn't happen very often this way, but it can. Typically, the most common site is right here, the outer third of the tube, the ampular area, because this is where what occurs? Conception occurs there, typically. So an ectopic pregnancy can occur because of any condition that decreases the lumen of the tube diameter. So the lumen of the tube is smaller than it should be. Sometimes if there was a tubal pregnancy before, there can be scar tissue. Scar tissue is the primary reason that you would have decreased lumen. So scar tissue also alters anything that alters or decreases the motility of the ovum can slow things down and cause a pregnancy to adhere there. Or an infection, pelvic inflammatory infection from an STD. Okay, congenital abnormalities of the tube, endometriosis, presence of an IUD, in vitro fertilization, because sometimes they'll fertilize the egg or the ovum with sperm and then place it back into the tube, because it can then ensue a normal process that it typically would when there's a fertilized ovum in the tube. But that can also cause a tubal pregnancy. If mom's older than 35 years old, she's more at risk for tubal pregnancy, and then smoking. So signs and symptoms: missed menses, early signs of pregnancy like breast tenderness, nausea. If she's got pain in her lower abdomen on one side or the other, or it could be a diffuse pain over the lower abdomen, but it's pain. And abdominal or adnexal is ovarian. When you see that term, it's ovarian. So tenderness, so either abdominal tenderness or ovarian on the side tenderness, spotting or bleeding into the abdomen, and then the bleeding may be so severe that it causes a hypovolemia. So if she's bleeding into the abdomen, it's going to make her abdomen very tender and firm like a board, because it's filling with blood. This is called Cullen sign. This is a symptom of abdominal bleeding, and typically we don't have this, right? But you've got some bruising around the umbilicus, abdominal bleeding. Okay, she might be dizzy, fainting from the hemorrhaging. And even though she's hemorrhaging inside, she could be hemorrhaging that we see it coming out, but it also could be an occult hemorrhage inside. So she still can have these items. So we take her blood pressure, we evaluate her, and determine, is there bleeding, internal bleeding going on? If there is, she could have what we call referred right shoulder pain from the blood raising in the abdomen and putting irritation on the subdiaphragmatic phrenic nerve. So if that's going on, that phrenic nerve can be referred up to the right shoulder. And if she gets shoulder pain, or if anybody gets shoulder pain, trauma patient, if they're hemorrhaging, that is a sign that she has internal bleeding. Okay, if the hemorrhage is profuse, she can go to hypovolemic shock. And if it's slow bleeding, again, she could have a rigid, tender abdomen. So this is a little video graphic of what can happen. You see it gets fertilized in the outer third, the ampulla area, but then it gets stuck in the more narrow area of the tube. Okay. So patients that present with an ectopic pregnancy, they present usually acutely ill. They're sick, they're nauseated, and they're in a lot of pain. They have to walk bent over because they can't stand up straight, or they get taken in via wheelchair. So this is a medical emergency. So anytime we have a patient that comes in Okay, let's say we have a patient that comes in who's pregnant that knows they're pregnant, couple of months pregnant, or maybe 9 weeks. They probably can't survive in the tube much longer than 9 weeks or so. But she knows she's pregnant. She comes in with lower abdominal pain, and she's really feeling the pain. This is the first thing we're going to think. Do an ultrasound, see where that pregnancy is. Is it in the uterus or is it in the tube? Let's say a female comes in and is not pregnant and has lower abdominal site on one side or the other pain, severe pain. It could be a cyst. It could be an ovarian cyst that ruptured. Those are very, very painful. But when she comes into ER, all you ER people, when she comes into ER with lower abdominal pain, the first thing you're going to do is a pregnancy test to see if she's pregnant. Even if she doesn't think she is, must rule out pregnancy here. And then do an ultrasound, go on to other areas of possibility for pain after that. Could be a ruptured cyst, as I mentioned, could be appendicitis. But the first thing you want to do is determine if she's got a pregnancy. Do an HCG test. If she has a pregnancy, if it's positive, then you do an ultrasound. Where is this pregnancy? Because if it's in the tube, she's going to OR immediately. All right, nursing interventions. IV, O2, vital signs. Does this sound like an ER nurse? Yeah. Okay, vaginal ultrasound. We're going to see where the pregnancy is, what's going on. Control her pain. Labs, check her labs for H&H. HCG, is it high? Is it low? And then prevent shock. NPO, because we know that surgery is the only way we're going to cure this and take the ectopic pregnancy out. Consent for surgery. And if she's Rh negative, again, we're going to give her RhoGAM after after whatever, she has it surgically removed. Well, it's going to be surgically removed. So after the surgery, we're going to give her RhoGAM. All right, and the surgery would be a laparoscopic surgery, normally, removal of the ectopic pregnancy. Okay, it's easier that way, it's quicker that way, less complications. So here you can see the tube has an ectopic pregnancy inside, and then this one is where it ruptures. So you can see all this dark red blood, and she can bleed out pretty quickly. Okay, showing some bleeding and blood clots here, left ovary there. All right, and then we've got a picture of a fetus that has been taken out along with the uterus and the tubes. Okay, and this fetus was stuck in the tube. And, it's hard to estimate how big that fetus is, but I don't think it's bigger than 9 weeks. And then this one, we've got twins over here. We've got a head here and a body, and then we've got a head here and a body. So this twin pregnancy got lodged in the tube and ended up having to surgically remove all of that. All right, and here's a post-mortem picture, or well, I don't know if the mom died in this picture or not. She may have, but a picture of a fetus in the tube as well. And the other part was the uterus. Okay, so now we're going to go on to yet another type of bleeding during pregnancy, molar pregnancies. So there is a couple of different names for this disorder. It's called a molar pregnancy. It's called gestational trophoblastic disease. It can be called hydatidiform mole. That's also molar pregnancy. But basically what this is, the trophoblastic cells are cells that the baby grows from. Grows into the morula, they duplicate, they multiply, and it becomes the baby. But when this process goes awry, it can proliferate. These cells, these normal cells, can just overproduce and go into a pathologic proliferation of these cells. The embryo ends up dying because these cells take up the uterus then. So it's an abnormal pathologic proliferation. There can be a benign hydatidiform. There can be gestational trophoblastic tumors, or it can go into a choriocarcinoma, it can actually go into a cancer. So two types of molar disorders. One is complete, where the baby is totally suffocated out of the pregnancy, or it can be a partial, where there's some trophoblastic cells and some fetal tissue. So membranes are still present. So here's a couple of pictures. These are those cells. They look like grape-like clusters. And this uterus is filled with this molar pregnancy. The fundal size, because these proliferate more and more and more, the fundal size increases higher than it should be. Blood and tissue passing out. Okay, so another vaginal bleeding episode here. There's no fetal heartbeat. The size of the fundus is larger than the dates that she presents in. And the HCG is higher level here because these cells produce the HCG. So we get a higher than normal HCG. Excessive nausea and vomiting due to the high HCG, because that is strictly related to that hormone, causes vomiting or causes nausea in the mom. And then this patient could develop an early pregnancy hypertension, pregnancy-induced hypertension. That is possible. Okay, let's see if there's anything else I wanted to say. Okay, so here's a gross picture, as an actual picture of these hydatidiform trophoblastic cells just reproducing, and you can see how this takes up all the room in the uterus. There's no room for baby, so the baby ends up dying. Here's some other pictures, microscopic views of these cells. Okay, here's a complete, takes up everything. Here's a partial. We do have a growing fetus. It is possible for a baby to grow in there and maybe just be taken early. But then there can be an invasive mole where it grows through the uterus into the body. And a choriocarcinoma is where it leaves the uterus and goes into other areas of the body. Okay. All right. So two basic lines of management: evacuation with a D&C or hysterectomy. You saw some of those pictures. They did take the uterus out. And then regular lines of following her up to detect any persistent disease. So she's followed by chemotherapy due to the invasive cancer potential of this disease. And it typically responds very well to the chemo. And then follow up of the HCG levels until it's 0. So we'll start doing it once a month after it comes back down to 0. We keep following it though once a month up to 6 to 12 months. And so she can't get pregnant. Her education is you cannot get pregnant during this time because the HCG will go up again for pregnancy. And that's how we're following this, is by the HCG level.